Thanks for coming down, man. You made a little road trip down to Cynthiana. You said it's the first time you've been in Cynthiana.
Yeah, never.
Welcome.
Never
Welcome
been.
to Cynthiana. We got Cody Lane. I'm old enough to probably have taught you in class in Pikeville.
You did.
Yeah,
You did all of our ortho lectures.
Did all the ortho lecture. I'm still doing that. But now I'm looking back at all the people who are matching in the years. I'm like, holy cow, I'm getting kind of old. So let's go backwards a little bit. Tell me where you grew up and did your training, all that stuff, so everybody's listening knows.
Yeah, I grew up in a small town, make Cynthiana look like a metropolis, Bonneville, Kentucky.
Population.
We had to do a little PowerPoint when we started residency, and I went back and looked at the census for, this would have been like 2014, 16, whatever it was. And it was, population was 200.
Nice.
Yeah.
It's still population 200. Your family still live there?
My dad still lives there. My mom moved to Elizabethtown, which is New York
also
City.
Metropolis, yeah,
New York City
Bonneville.
compared to Bonneville. And
How far is Elizabethtown from Bonneville? Like 10 minutes, 15?
it's probably about 15. I actually ended up going to high school at Elizabethtown High School.
Okay.
So it was 15-minute drive every day. It wasn't bad at all.
So high school, Elizabethtown, where'd you go to college, undergrad?
Morehead State.
Morehead State Eagles.
Go Eagles.
That's right.
Did you go to Morehead?
No, I went to Pikeville.
You went to Pikeville?
Undergrad, yeah.
Nice.
So Morehead, and then we know you ended up at I don't know if it was KYCOM then or if it's PCSOM, but KYCOM, which is now.
It was KYCOM then. That was in 2014.
2014 you started, so you finished 18.
Yep.
And then went to residency in Dayton, Ohio at Grandview
Yes, sir.
with our good friend, Dr. Bamberger.
Dr. Brent Bamberger.
Yeah, so we were just talking about him, how big and tall he is and intimidating he is, but he was friends with my program director, Paul Matino, so we kind of knew each other in passing. And I rotated there for 2 weeks, I think. My path to ortho was crazy. I told you guys a story when, I don't know if you remember, but the last hour for lecture, I would just turn off all the cameras and say, okay, I'm going to talk to you about real world stuff.
Yeah.
Let's forget the ortho stuff. You guys can learn that later if you're interested. My track to orthopedics was crazy because I didn't know I wanted to do it. And I knew I wanted to do something in surgery because the days went by fast when I was doing surgery. But then I met the CEO of Orlando Regional at a golf tournament.
Oh, nice.
And in Winchester at the Memorial. And I was playing against him. I beat his tail. And he was like, well, I'm the CEO. His brother lived in Winchester or something like that. I'm the CEO of the hospital, so you should come down there and rotate. And I was like, okay. And at the time, and I don't know how it was when you went through, we just didn't have many electives. Like you had kind of 2 internal medicine electives and 2 surgery electives, and that was it. I think it got a little bit better.
In medical school?
Yeah, medical school.
Yeah.
When I went, it was like, we're training primary care doctors in the mountains, and that's just what we do.
Yep.
So if you want to do orthopedics, good luck. And I didn't have any help. I didn't have any guidance on how to go through. So I kind of committed to, like, when I get out and come back, I'm going to try to help everybody.
Yeah.
That wants to do orthopedics. So I was really late to the game. I rotated in June of my 4th year as it's starting and hadn't even done an orthopedic rotation yet.
Oh, wow.
Didn't even know I wanted to do orthopedics yet. So I did Orlando trauma surgery, and it was awful. I hated it. I hated everything about it. I hated the trauma bay. I hated the babysitting people in ICU forever with wound vacs on their belly. So everything about it I hated, and I knew for sure I didn't want to do trauma surgery at that point. But then every time we'd have a big trauma, there's these dudes coming in backpacks and like freaking power tools, like zipping people's legs and putting X-fixes on. And I was like, who are those guys? Like, that sounds like the pit crew that I want to join. So I ended up talking to them. And, that's how I got introduced to orthopedics, like in the trauma bay of Orlando Regional. And then started paying attention to what they were doing. But one of the residents there told me, hey, there's a guy in Largo that if you want to do orthopedics, you should rotate with him because he's kind of crazy and he lets medical students operate. And I was like, I'm in. And the guy's name's John Harker.
Yep.
He's an absolute beast. And so I called. I'm in June in Orlando. I want to rotate in July in Largo. And he's like, that's not how it works. Like, we're in Largo, Florida. There's tons of buddies that want to rotate here. So if you come, it's too late. And I was like, I don't think you understand. I don't have any time. Please, if I show up, can I rotate here? And he's like, I don't know, man. You can try to do whatever you want. So I somehow snaggle my way into Largo. And at that point, there was no residency program there.
Oh, really?
It was just Harker by himself. So they hadn't started the residency program yet, but there was hints that he was going to start a residency program. So I was like, it's a good place to rotate because I can be one of the first residents with Harker. And I love the rotation. That guy was an absolute beast. Like, we would be from St. Pete to Largo to Palm Harbor to like all up the coast operating on the same day in all these different facilities. And I was like, this is awesome. So I really fell in love with it when I was rotating with him. And his PA left for a week, so I got to kind of be the first assist and, and total hips and total knees and all this stuff. So I drank the Kool-Aid at that point. But then I had a problem, which is like, I want to do orthopedics and I'm out of time. There's no audition rotations. Those things have already flown. Like, everybody who's gunning to do orthopedics has already done their stuff.
Yeah.
And now we're going into August of my last year, and I got a rotation in Pikeville or something in August. I don't know where I'm in Hazard in August. So now I'm September before I can even go anywhere to a program. And then I ended
matches
up,
in November or something.
Yeah, exactly. So September, and the match is going to like start or go down in November, whenever it is, and then the results will come out in February. I don't remember exactly what the timeline was. So it's really behind the timeline, and I had started going crazy, like, I need to rotate here, I need to rotate there, and our school really didn't set it up so you could do it that way. So I started like blitzing. I went to Dearborn. I spent 2 weeks in Dayton. I was just going anywhere I could go to try to figure out and get some face time. And ended up interviewing in New Jersey, at Dayton, doctors in Columbus, Riverside, California. What the heck? You take anything you want at this point,
absolutely.
like wherever you're going to get interviewed. And so I don't know who those people are. They may still be around, but I'll just say it. Like, Riverside said they were going to match me first. And I was kind of dumb and naive, like knowing. So I was like, okay, we're set. Like, that's what we do. I didn't know all the program directors told everybody that.
Yeah.
Like, no one gave me that hint.
It's a trap.
It's not even a trap. It's just like, okay, we're going to rank you higher. You're our person. And I just believed him. So that's the only person I ranked. So I learned that really early on. Like, tell everybody, rank all your programs.
Yeah.
Because I didn't match. Like, the match rolls through. And I put Riverside because they told me that they wanted me as a resident. And it didn't match. And so I was like, there must be some mistake. Like, you told me.
I got bamboozled.
Well, it wasn't. I mean, retrospectively looking back, they just want to get everybody interested in their program who can match them. And I just didn't understand that they may tell you that they're going to rank you when they don't.
Yeah.
Or maybe they did rank me like 20th or whatever it was.
Or what, they probably had 3 or 4. And
whoever.
you got matched 5th, you know.
So, I'm expecting when match day comes out, like, we're good. Like, we're going to residency in California, which thank God that didn't happen, to be honest. But I would have went for sure that late in the game, and then ended up, there's some places still, I'm old enough that they only took interns as residency, and Oklahoma City was one of them.
Yeah.
And that was wild. Like, I show up, and there was another place in like St. Augustine, and then maybe something in like further south in Florida. They were all getting ready to start programs, and they were only going to take interns, so they can bring the intern class in. So I was set to go to Florida, and not that the voice of God told me something different, but I just kind of knew, like, I just had this thing that I needed to go to Oklahoma City.
Yeah.
I didn't understand what it was and didn't question it. So I just scrambled to Oklahoma City the same day as the match, the next day. We didn't know anything about it. I barely knew where Oklahoma was on a map. And so that's the story I tell every single medical student, because you hear lots of stuff in your ear. You got to have this board score. You got to be this class rank. You got to do this and you got to do that. And the truth is like, you just got to be in tune with whatever God's doing in your life.
That's right.
And if you do that, you're probably going to end up where you're supposed to be. So Oklahoma City was the biggest blessing ever in the history, because we had like 30 attendings for 10 residents.
That's perfect.
So all day, every day.
Yeah.
I went to, not to incriminate myself, I think that it's past that time. I went to clinic like 5 times in 5 years because we operated all day, every day.
I think it was kind of similar. I rotated in Oklahoma City, and it was kind of
Yeah, we didn't go to clinic.
similar.
Ever.
Yeah.
And our program director at that time said, you can learn how to do clinic, but there's only a 5-year period where you're going to learn how to operate.
Yeah.
And so that's what we did. We went after it. And it was wild. But the reason I'm telling you this whole big, long story was everybody's path is different on how, whatever God has in mind. I don't know how it was when you started and went to E-Town and Moorhead and came to Pikeville and decided to do orthopedics, but there's a lot of talk. There's a lot of banter about this is what you have to do. This is what and then now that the ACGME and the DO stuff have merged, all the rules are broken now. Because used to it was find your classmate who's been into a program somewhere before, rotate there, kill it, and you'll get an interview. And now it's like, good luck.
Yeah.
Like I don't know what to tell medical students now except step one is pass fail.
Yep.
So used to it could be like kill the boards and you're going to get an interview. The guy who rotated as a rotating intern who got the other spot for me had like a 797 on his boards, which is like you miss one question.
Yeah, it's crushing.
It's 800's a perfect score at that time. I don't know what they were now, but at that time 800 was perfect. So he missed like a question, and was from Texas and wanted to go to an MD program in Texas, and they wouldn't even interview him.
Yeah,
like #1 board taker in the country on USMLE and COMLEX, and they didn't interview him because he was a DO. And that's the good thing. That part's gone away. But the mesh that's happened has created competition that's insane.
Yeah, it's almost harder now. I
mean, I think it is harder.
I think I was one of the kind of in the last class or two in the kind of the old fashioned. It was the ACGME and the DOs had kind of meshed, but it was still kind of there's DO programs and there's MD programs. So it was like you said, it was like you need to have some decent scores and But that audition rotation was
that's make or break
key
when you show up.
And you're right, you go meet with some people that had matched ortho, and at Pikeville
there was just a few of us.
There was not very many, so it was kind of tough
for sure.
But during our interview process towards the end of my residency, it was getting very challenging to pick from these people because board scores can't even. You either passed or you didn't. And
that was the most fun actually that I had in residency was the interview week because we were bad. We were bad to people. We put them in. We'd had simulated shoulder scope labs come in, but we'd also have all the attendings show up and put them up into fracture conference like X-rays in real time during the interview, and we were bad to them. And then we put a wobbly chair on their chair so it would wobble and make noise while they're sitting there just to irritate them. The guy I was telling you about, Matino, would always yell at him because they would always want to touch the X-rays. Yeah. And he was like, "Can you feel that fracture?" And they were like, "No." And he's like, "Please quit touching the X-ray." Like, you got to tell us what you're doing. So we were so bad to residents during that interview, but it was fun when I wasn't the one doing it.
Oh yeah.
When I was creating the pain, it was fun. So you finished residency at Grandview and ended up in Maysville, Kentucky now. So you're at, it's called Meadowview Hospital in Maysville. And I don't know the first time we connected, but I think it was like, I'm coming to town, like send me some joints. Is that how we reconnected?
I don't remember, honestly. I feel like you, I don't know, maybe you saw it on Facebook or something and you had reached out.
Yeah.
And I think you asked me if I did anterior hips or something. Because
Yeah.
I was like, send them all my way.
So I was in Tampa and then basically had morphed my practice into a sports medicine practice. And so when COVID hit, I was in private practice by myself. There's another guy who was a joints guy in private practice by himself. So we had this like unofficial contract to try to help each other survive. Yeah. So I quit doing hips and knees, and he quit doing shoulder scopes and knee scopes.
Yeah, there's so limited.
So he sent me the shoulder scopes and the knee scopes, and I sent him the hips and knees, and we were like, we're going to try to stay afloat and keep this thing alive. And so I quit doing hips in 2020. And then when I came back to Kentucky, which is in 22, I didn't have the help that I needed because I do an old school modified Harding anterior lateral approach, and it's 100% dependent on who's running the leg.
Oh yeah.
And I didn't have that person here. Yeah. And so I was like, I just can't. Like, I can't safely do your hip. At the same rate, the anterior hip went away from me after residency because we didn't have a table. So when I came back, there wasn't really many people doing like flat table, no table anterior hips. So I didn't have anything that now is a thing. People do it without tables, but I didn't have a table, so I didn't do anterior hips. So I'm still doing old school anterior lateral modified Harding approach, which is inferior in the initial post-op phase. Long term, it's the same.
Yeah.
But inferior to an anterior hip. And if you're marketing yourself, everyone who's doing anterior hips kind of grab that business.
Yeah.
And so I decided like I'm not doing hips because I don't have the personnel to run the leg that I want, and then I'll need to train somebody. So I ended up hiring a PA, and she's fine at it. Now that's how I do hemis.
Yeah.
But as far as total hips go, we decided not to because my product compared to your product is fairly inferior for the acute post-op phase.
Yeah.
And I think long-term it's probably the same.
I think so.
But short-term, there's no question that there's a difference.
Yeah, I like the anterior approach, at least in I agree. I mean, I think most of the literature says that, 1 to 2 years, they do pretty much equivalent, but I'd say the majority of people are either probably doing anterior or posterior. I think the anterior lateral is probably a little less
It might
common.
be a dying fashion.
I mean, it's more stable than a posterior,
Yeah.
especially acutely, but I tell my patients, outside of a major complication, you can do whatever you want. And
For sure. Yeah, no, for sure. But there is, I mean, and you can tell me this, like, do you do most of your hips anterior or are you doing
all
of them
I do
anterior?
them all.
Yeah.
Yeah.
So early on in your training in the residency, I'm guessing that's where you learned to cable femurs through an anterior approach. And like, how did you get the 90% that are great? How did you deal with the 10% that turned to crap?
It's a pain in the butt.
Yeah.
I think one of the biggest thing, at least in residency and in my practice, I think the biggest complication that we routinely saw with the anterior approach was that, that proximal incision, especially if you had a little bit of a pannus, it gets a little bit soupy, and it's mostly where we're just putting that retractor just on a very narrow bridge. I actually moved to a bikini style incision.
Yeah, sure.
And you're putting that pressure.
It changed most of it.
I've had zero wound complications since I switched to that. Now the fractures can be challenging. I think most of the time, depending on the fracture, obviously, but usually, especially with the bikini now, you're not going to be able to fix that through the bikini. You're just going to make a lateral incision.
Yeah. Like if you crack a calcar, you're saying.
Yeah.
Yeah.
If it's right off the lesser, you're probably okay. You can get it with a cable.
Yeah.
It's challenging
For sure.
but if it goes very distal, you're just going to have to make a window and fix it. But the good thing is you're still not violating that posterior capsule and maintaining some stability.
Yeah, sure. That's not sexy to talk about, but it's real.
Yeah.
Like if you've not cracked any calcars, you haven't done enough hips. So.
That's what I want to. Dr. John Urs up in Dayton. He said, "You haven't cracked a
Speaking of
calcar."
John Urs, like you had to know everything that goes with everything and nothing to do with orthopedics.
Oh yeah.
He would want to know who won the triathlon in the 1980 Olympics in Los Angeles.
And if you didn't know, he had a PowerPoint to show you. Yeah.
Exactly. Yeah, I remember him in my 2 weeks there, and he was a character for sure.
Yeah.
So started in Maysville. Did you do a fellowship in joints?
Nope.
So you just kind of had you wanted to fill a need or fill a void, and is that how your affinity for doing the joints, or is it like I just want to do general orthopedics?
Well, yeah, going in when I was in I think my third year of residency, I knew I wanted to kind of do a little bit of everything, and I didn't want to live in a big city.
Yeah.
I wanted to live in a small town.
Why not, man? You're from a town of 200.
Yeah, exactly. Lexington's way too busy for me.
Yeah, that's nerve-wracking, isn't it?
But so I just wanted to do general orthopedics, and I felt that my residency training was good enough, or it wasn't good enough. It was great that I didn't need a fellowship to do what I was going to do.
Yeah, for sure. Same. Like we're blessed. We're both blessed, and I'll just go back and I don't care who's listening. We'll just tell them like the old school DO programs. You just operated a lot.
Oh yeah.
So your competency had nothing to do with your ability to operate. You didn't have to go do a fellowship because you hadn't seen that amount of volume of hips, or because you hadn't done that many distal radiuses, or you hadn't done. ACLs or whatever it is, you had enough exposure to do it. So that's the same for me. When I came out, I was like, I'm going to be a blue collar orthopedist. I'm going to make my living by operating on people. And I did that 5,000 times in residency.
Yep.
Probably don't need to do a fellowship. Now, the reason to do a fellowship, there's multiple reasons. One is if you're not competent enough at what you want to do and you need more exposure to it. Mm-hmm. Some people, you roll the dice and you may go train at a university that's high on trauma. You may never have to do a trauma fellowship to see everything under the moon, but you may have done 4 or 5 ACLs.
Can't scope a knee.
If you can't scope a knee, you need to go figure out how to scope a knee.
Yep.
If you want to do sports medicine, probably have to do a fellowship. And so for we're well-rounded enough during the residency that I didn't feel like I needed to do that, and I didn't care about the fellowship component to market myself.
Yeah.
If I wanted to say I was a hand surgeon, I'd have to do a hand fellowship.
Yep.
If I wanted to say I was a joint surgeon, I'd have to do a joint fellowship. I ended up in Mount Sterling, Kentucky. Like, I didn't have to say anything.
Yep.
I just had to work.
Surgeon.
Yeah, I just had to work. And I had a little bit of some of our trainers in this initially, which is like I just said yes to everything. I look back at some X-rays and I'm like, we did that in Mount Sterling. You can build a program anywhere.
Yeah.
In any part. And so with the right help and the right surgeon and the right staff, then you can be successful no matter what. And so end up in Maysville. And how long you been out there now?
2 years and
2 years.
10 days.
Who's counting?
Yeah.
2 years and 10 days. And we were just talking off camera where you started, like it was a great match for you. Like, it was a good place to land. And you ended up taking some call there and doing some general orthopedics. And what's your practice like day to day? What percentage you think is joints and what percentage is general sports? How's the breakdown?
Man, actually, because I was just filling up, like, I don't know, like 6-8 months ago, I was doing like the board.
Yeah.
The second part of your boards and filling out the list. So I think 30% of my practice is hand. Yeah. Probably 30% is probably joints between knees, mostly knees and hips, and then some shoulders.
Okay.
And then true sports, it's relatively low. Yeah. But lots of scopes on shoulders and knees for more degenerative stuff.
Gotcha. What about what do you want it to be? Do you love that mix, or do you want it to shift more towards joints, or do you want it to shift more towards hand? Like, what do you think?
Oh, I love doing hips and knees. If I could do hip and knee replacement 75% of the time, I'd be probably pretty happy.
No, I gotcha.
Mix it in.
And then your draw area, where do people come from? Do they come across Ohio River?
Oh, yeah, probably. I don't know the numbers, but probably at least 30-40% of our practice is from Ohio, just because we're a border
the geography.
town. I got patients from Columbus, Ohio. I got patients from Mount Orab.
Yeah,
a few from here that you've sent.
Well, they had to pass Dayton from Columbus, so you just wave at Grandview on the way by and say sorry, they're too busy there.
Yeah, I don't know how that works, but they find their way in.
Sure. Yeah. Well, one of the things is, and I think this is true for you, one of the things that's important is just how you treat people. Like if you're trying to build a practice and you're trying to go from start, I did it a little bit earlier than you have ago, but a lot of it comes down to just how you treat people. And it doesn't matter what small town you're in. If you're in Maysville, you're in Cynthiana, you're in Mount Sterling, Kentucky. Like what people want most is competency. Okay, well, check, you should do that. You should be good at what you're doing. But what they also desire is like somebody that they think's on their team or they trust. And so it's been a big deal for the people that trained in our residency just had that beat in our head. Yeah. Because all of our attendings are in private practice. And if you don't do well, no one comes to you. You don't have a referral base. It's built in through these big multi-specialty groups. Yeah. You have to do well by people. And so most of us going out, and it's the same for the guys here at Grandview, like, you look through the whole structure and you get a high volume of stuff, but really it comes down to how you treat people. Yeah. And if you do it well and you're very good at what you do, then you become successful pretty fast. But what do you think about how busy your practice is compared to how busy you want it to be volume-wise? And I'll tell you why I'm asking here in a minute.
Probably 85% where I want to be.
Because it takes a while.
Yeah.
So I think the numbers are like 3.5 years.
Yeah.
To kind of hit the point where it's like, okay, this is steady. and the ebbs and flows aren't as bad.
Yeah.
Because there'll be times where you're like, I don't have any surgeries this week. And then there's times where you're like, I don't have time for the surgeries this week. Oh. And so some of that fades out and kind of goes. And I think it takes about 3 years or so for that to happen. So you're still pushing towards that 2 years in, and you'll still, your best referring patient is whatever the last one you just operated on. Like that's your billboard. That's how people are going to come and see you. Talk about showing up in Maysville. You have a partner who's there in Maysville, Dr. Owens, right? Mm-hmm. And he'd been there for about 600 years before you came. Everyone in Maysville kind of knew he was there. What's that transition been like? Kind of joining with him. It's been. Do you guys? Hey, I really like this. I'll do this surgery. You really like this, or you just kind of race together as fast as you can?
Oh, it's been great. Dr. Owens is awesome. He's actually the reason I went to Maysville. Going back, how everything kind of works out like it's supposed to. It's like I was kind of in your boat. I wanted to do surgery, but I definitely did not want to do orthopedic surgery because it had this. Stigma of it's not even medicine. It's just a bunch of jocks, right?
Is it?
Yeah.
I didn't know. I haven't got the memo yet, but I mean, I guess it could be medicine.
But I didn't want to do it, and I wanted to do general surgery, and I was doing the rotation actually in Flemingsburg, and I just didn't like it. Yeah. And Dr. KOMA, who was there at the time, he would add it on a tibial nail.
Oh, you saw that?
And I was like, hey, can I scrub with you and just check it out? And I saw it. I'm like,
I'm in.
That's what I want to do.
You mean I got to take this hammer and beat this nail?
Yeah, that's great.
So where did you do your rotations? Is it in Fleming? Where was your hub spot for?
Mount Sterling, actually. But, I did rotations from Moorhead, Sterling, Winchester, Lexington.
Gotcha.
And then most of my stuff I did with ortho in medical school was actually at Meadowview with Dr. Coomer and Dr. Owens and Dr. Harris at the time.
I gotcha.
So, when I was looking for jobs that third year because I
kind of felt familiar, yeah.
Well, I was looking, like we talked about, I wasn't looking to do a fellowship, but I wanted to make sure I had a job before I made that decision. And he was the only one there, and I called him up. I'm like, hey, is this job really available? Yeah. He's like, yeah, I interviewed and it worked out.
Nice.
So he was a big reason I went there because I knew the guy, and he was awesome to work with. And we meshed really well. Not really are we like, hey, you do this, I'll do that. But there's some cases that, I do that he doesn't do, like some niche stuff. And
well, it was crazy. Like, it didn't turn out. When you're a medical student and a resident, you don't have really a full idea of what it means when you come out.
No,
it's not a rude awakening, but it's an awakening. One of the reasons I went to Mount Sterling is Jim Rollins and Anoop Chadha operated together on total joints.
Oh, really?
And it was a dance of beauty. And I thought, well, no big deal. I'll come. We'll find my person, and then we'll go knock these 10 joints out really fast. Because they had developed over time a relationship over 10 years. They didn't have to talk. They didn't have to look. But it was literally this work of art in their joint where one person would be sawing, one person cut, the next person saw, one person cut. And I'd never seen anything like it. I was completely drawn to their practice because of that, and they literally didn't talk to each other during the case, but it was a dance that they knew very well.
That's wild.
And I was like, I just want that. That'd be awesome.
Yeah.
So I'll go build a practice. We'll find my fourth person, and we'll just do that all day. It'll be awesome. It didn't turn out that way, but that's like they had 2 surgeons doing the case, and they did a full load of each day. Everybody had their own schedule. But when the joint came in together, this boom, 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 and it was this dance that it was awesome.
It's just art.
Yeah, it was art. It literally was, and I had some joint guys who were insanely fast and insanely efficient. So they may have been faster than Jim and Anoop, but there's nothing like that dance that you saw. And for me, I was like, it felt like operating with your buddy in residency.
Just having fun.
Yeah. And I was like, well, I want to have fun. Like and so that's really one of the reasons I ended up in Mount Sterling was because of how they worked together. Now, it didn't work out. I didn't find a partner. We didn't have that fourth person. I ended up in Tampa, Florida, whatever. But that was one of the reasons I went was because they really kind of meshed together so well that it was a dance. They trained in the same residency spot, I think a year or 2 apart. It's the same training. And it was wild. And I don't know if they still do it. They may still do it.
I need to go watch that.
It was a thing of beauty for sure. And they were navigating knees early on. They used Stryker for navigation. And it was pre-Mako, before Stryker was involved with Mako. And I hated it.
Is it that ortho line thing?
No, even before that.
Oh, really?
Like literally they were putting two pins in the tibia, and putting trackers on. One tracker, two pins, and then they would pin the femur. And for me, I hated it. Like I trained in a time where most of my attendings were like, this is crap.
Yeah.
Like we're not using this robot crap. And so I wasn't there. I didn't do navigated stuff, but then I would watch them navigate and I was like, it's just going to slow you down. It didn't for them.
They had it figured out.
Like they had it figured out, and that was part of the dance. And I was like, man, y'all pretty slick.
That's awesome.
And that's literally how I ended up in Mount Sterling, among other reasons.
Yeah.
But God puts you where He wants you, when He wants you, for sure. So, what about personal stuff? Family? What's going on in Maysville with Cody?
Yeah, I got a wife and 3 kids.
Yeah,
6'4" and 20 months.
6'4" and 20 years old. No, 20 months.
20 months ish.
Yeah. So boys, girls. What do you got?
I got a boy and 2 girls.
Okay. So at least you're not a specialist.
No.
So you got one of each.
Yeah. Diverse.
Exactly. And then what do you guys do for, you just said you took a week off and you're paying for it now, but what do you guys like to do for fun?
Oh, my son likes to do everything: baseball, basketball, golf,
every sport,
all the soccer.
The 6-year-old.
Yep.
Yeah.
My daughter's into dance and dolls and whatever.
Now, how big is Maysville as a town? Like, is it small?
It's I don't know the number actually. It's probably 10,000 people.
Okay, so not insanely small. You don't necessarily have to be like the head of the Christmas parade every year, right? So,
not necessarily,
but you could be if you wanted to.
Could be, yeah.
And then, what about the high school athletics there? Do you guys take care of them?
We do. Yeah. We cover. Me and Dr. Owens we go all the football games.
Yeah.
Pretty much all the basketball games.
I gotcha.
Some of the smaller sports.
At Mason County High School?
Mason County.
Yeah. The Royals.
The Royals, yeah. We try to cover like wrestling and track, but we don't get to make all those.
Yeah, for sure. You still have to work sometime.
Yeah.
Yeah. We can't all just get on the bus and travel wrestling.
Yeah.
And then how does your practice work from the standpoint of clinic versus surgery? How much do you?
Yeah, so I'm in clinic Mondays, Wednesdays, and half day Fridays, and then OR Tuesdays and Thursdays.
Yeah.
And then me and Dr. Owens are pretty fortunate. We can kind of sneak some stuff in if somebody's not operating, which he's operating on Mondays and Fridays. So that leaves Wednesday available. If we have any add-on stuff, we can usually sneak a room in. And
sounds good. And then what about not just the clinic side and how you do clinic and surgery, but what's the flow happen for you, like the ebbs and flows as far as call goes? It's not, we just talked about it off camera. It's not like you're on call at a level 1 trauma center and you're operating every night.
Yeah, no, it's we get community trauma, obviously hips and wrists and ankles, but we don't get that very acute stuff, acetabulum fractures and stuff like that.
Same. So. Yeah. So I'm in Cynthiana most of the time now. And we call it gentleman orthopedics. The stuff that you have the resources you need. If it's an isolated orthopedic injury, we take care of. When you start getting distracting injuries and car wrecks and all kinds of stuff that probably needs to go down the road a little bit. Where does the trauma go from Maysville? Does it go east to like Huntington, or where does it go?
It's either Lexington or Cincinnati.
Gotcha. Lexington or Cincinnati. Gotcha.
Kind of just depends.
Yeah, who's not on divert?
Yeah, exactly.
Yeah, for sure. And then what about the transition of, do you do any of your joints as an outpatient? You let them go home?
80%.
Yeah.
Probably.
So what is that transition? Is that the way you just did it from the start, or have you been slowly doing that?
No, it's pretty much how I started in residency. We were,
Yeah.
mostly outpatient. Obviously if you have someone that can't go home safely or they don't have anybody to go home with, they'll end up going to a rehab facility. But, it's probably only about 20% of my patients. Most people are in and out same day and
Gotcha.
get back to life.
We know this internally, but maybe everybody's listening that doesn't know, like, what's the difference in a total hip and a total knee as far as rehab goes?
Oh.
If you were going to have one, which one would you rather have?
Hip.
Exactly.
No questions.
Yeah. Because they literally, it's a life-changing surgery.
Yes.
Almost immediately. They wake up with the arthritis pain that they had, it's gone.
Gone.
And when you're doing the bikini approach and the anterior hip, and they have the benefit of not cutting muscles and not doing that stuff, they just feel really good really early.
Oh, yeah.
So they ditch the walkers and the canes and all that stuff pretty fast. But talk about the knees then, which is the more difficult of the two rehabs. And when you're doing those in outpatient, what's your opinion on what resources they need to be aware of in order to have a good outcome and not get stiff?
Man, I think I do a Mako. I don't know if you do that or not. Do you do?
No,
knee,
I don't do.
You just regular?
I do. Yeah, I do knee replacements. I use CT guided patient specific cutting blocks in order to do all my planning up front.
You doing conformist or
Medacta?
Medacta. Okay.
Yeah. So I try to do all the legwork before the surgery happens. Yeah. Some of that has to do with like the staff and how much they're not used to joint volume. And it helps me not have to navigate through the navigation portion of it. Yeah. We dabbled with like doing augmented reality. There's an augmented reality glasses with Medacta. I put them on and I was like, I'm not disoriented. It's just a little small camera in the corner. They need some work. But I have the Apple Vision Pros just for myself. Mm-hmm. If they can incorporate that where you're in augmented reality, not virtual reality, mm-hmm. then I think that'll probably have some role in cutting, whatever your preference is for. Like for me, I still do mechanical alignment. I didn't buy into the kinematic alignment with Medacta. You did?
I'm bought into the kinematics.
Yeah, so I don't want one patella tracking problem. I'll take 0, but I'm also old. So it's really hard to teach a new dog old tricks, and it's hard to teach an old dog new tricks.
For sure.
So I haven't made the conversion to KA, but I do like Medacta's sphere and how stable it is. Mm-hmm. So I like it, but I put all of them in mechanical alignment. And by allowing me to do that with patient-specific guides, I don't have to worry about the 180. I just know I have it dialed.
I think if you're doing, robotics or custom cutting blocks, I think one of the better things about those types are, the way that you do that knee is, if you were just doing mechanical alignment, with standard jigs, you're probably doing, some MCL peppering and, releasing a lot of soft tissue structures quite often. At least with the Mako, the way I do it, and I'm assuming the way that your cutting blocks go, you're not having to do as many soft tissue releases. That's right. And
the other thing it allows me to do is just put the smallest poly in.
Yeah.
100%. I don't have to guess. Yeah. We're putting a 10 in.
Every time.
And basically every time. But here's the thing that was weird, and I'll talk to you about it here. From the traditional way, if you're doing traditional instrumentation, almost every total knee system will have a measuring device, a finger that you put on the tibia and decide how much you're going to cut. Mm-hmm. And the only thing you have to do if you're going to make a mechanical alignment is make a good cut. Yep. Make a flat cut and with the alignment that you measured. No one can answer this question for me. Our traditional fingers that we use for worn out medial knees for traditional varus knee may cut 1 or 3 off the most affected side and 10 off the unaffected side.
Yep.
It's kind of standard instrumentation. I haven't had a single CT ever that's cut 3 and 10. Never. In their whole mapping. And so it's been an eye-opening process to me to say, one of those two things are wrong to put mechanical alignment in. Mm-hmm. Either the traditional instrumentation saying I'm taking 3 or 1 off the most affected side, or I'm taking 10 off the least affected side, doesn't add up if you look at what happens on the CT scan. So my question is which of those are wrong?
I think if you're doing a standard, we're talking way too much shop on this podcast,
okay.
Right?
Yeah, that's okay. We'll get to other places.
If you're using an exponential guide and you're cutting 1 or 3, whatever, off the medial side on a varus knee, are you putting that in a little bit of varus to take less than 10 off the Lateral side?
1,000%.
Yeah.
But what happens is that doesn't match to what you measure when you make your measured cuts with the cutting blocks, because you may take 5 and 7. So that gap of 7, and it goes over, and maybe you take less than that. Like you said, you put in a little bit of errors. Those still don't match.
Are you saying if you're measuring the block that you cut?
No, I'm saying the measurements that I get preoperatively now.
I got you.
I go through all those and say, if I was using traditional instrumentation, this is what I would have done.
Yeah.
It doesn't match what I'm getting on the scans. And so one of them are right and one of them's wrong. Neither of them are bad.
Yeah.
You can still get a highly functional knee in a good position that's not going to wear out, but they don't match. So my question is the finger wrong? Should we take 3 and 10, or should we take 1 and 10? Every company's different on that one. Or is it that those, sometimes I've taken 7 and 7, and I was like, this is a varus knee.
It's flat cut.
That's a flat cut, but you're not supposed to have a flat cut in a varus knee.
No.
And so then I'm like, do you trust this? So I started making adjustments on slope. I started making adjustments on the cuts. And what I found is that if you'll go through and use whatever mechanism they're using to do the cut, you're better off.
Makes sense.
So I've recut probably 0 since I said, let's use the formula. I recut a lot when I was making my adjustments preoperatively. And I was like, I don't like it. Give me the step down cutting block. Because I trained in a time where, like, you would cut the distal femur and say, does that look like a butterfly? Yeah, it looks pretty good.
Perfect.
Doesn't look like a butterfly. Is it too fat of a butterfly or not fat enough? We want to cut more off the distal femur.
I think there's still some things that we were like that too. You kind of wanted that distal femur to almost be 2 separate pieces when you cut it, unless they were super tight and you had a flexion contracture or whatever.
Yeah.
But
And it's changed a lot with the cutting blocks. 'Cause I'm making these cuts and I'm like, I wouldn't have done that.
I know.
That's traditional instrumentation.
It's the same thing with the robot. Like, the Mako, you do that CT scan before, and you can really adjust your cuts. And, we talk about you definitely don't want to internally rotate the femur or what have you when you're making those cuts. And sometimes we do that on a robot, and it looks absolutely perfect. And you're like, there's no way in God's green earth I would have done that.
That was my experience with the Mako when it first came out, but it wasn't. I think it was Mako. It used to be owned by a different company.
Yeah.
And we had the unis that we were doing, and it's like, I don't believe this. Like, there's no way that I can. The guy that was my attending, Tom Tkach, would be like, get that stupid robot out of here. Yeah. Like, that goes against everything I ever did before. And then now you start looking at it, you're like, well, I mean, if it's repeatable.
Yep. And they do well. And I think the literature supports that.
I think so too.
Robotics do better, a little better, a little quicker. They all do the same.
I don't know if we probably get in a little trouble saying what I think robotics are. I think it's a great marketing tool.
Yeah.
I do think it gives you repeatability, and you can rest easy in that you can do the same thing repetitively over and over again. And there's some benefit in that. I think it was mainly used as a marketing tool early on. Probably not now. Like, we have a robot. We have a robot. Not all robots are made the same.
No, they're not.
I won't call out any names, but they're not all the same. And a lot of it is just the equipment that you get. Like, I can give you a Mako, or I can give you a Rosa, and whatever you use best is what you should use.
Yeah. 100%.
That's just how it works.
Whatever implant works for you.
Yeah, for sure. And then I hate that they're implant specific, but
I said the same thing.
We'll go with that. Yeah. Like, give me something that's not tied to the industry, so I can decide what implants we use.
I agree.
But I don't do reps very well. Like, they don't like me very much. And I don't know where it came from. I do know exactly where it came from, but it's an abnormal obsession. So there was an act come out called the Sunshine Act, where all the reps had to put, how much money they spent on your practice for food, or if they took you to a training and you were learning a new technology. Like, it all just came out, and it's posted for everyone to look at. Like, what's our relationship to industry? The first 2 years they posted out, mine was 0. So $0. And I was like, that's going to be it. We're going 0 for life.
Forever.
Then somebody brought in donuts and coffee and had $31 on it the next year. And I was like, okay, who let them in? And so it became this weird obsession. But the other part was, they're kind of, they may listen to this and be mad, but they're trained to like befriend the surgeon. That's part of their training. And I never really wanted the relationship to be tight enough that if I decided to use a different implant, I was hurting somebody that I knew, it's family. So I really went away from the industry stuff. And then they're like, can we bring you lunch? And I was like, nope. Can we meet you in the clinic? Nope. Well, what if you need, I'll call you. And so I'm hard on them. So they don't love that. But I mean, occasionally if something comes out new, I'll call them.
Yeah.
Like, hey, I need to see this. Can you bring it over and let's take a look at it? But they laugh at me in clinic because like all the reps are calling all the time. Can we bring lunch? Can we bring lunch? I was like, no, we're good.
They try.
They try. I mean, they should. It's every day. It's part of their job. They should try. But it's a tough job. It's a tough gig.
I wouldn't want it.
Especially like I said, I don't have like personal relationships, but I'll do some trauma stuff and end up, having a rep come out who lives in Lexington. They'll come to Cynthiana. I just put a K-wire in. I was like,
sorry, man.
Like we didn't need your stuff, but if we needed it, we needed to have it here. So
it's part of their gig.
It's part of the nature of their job. But I'm kind of tough on them. They don't like me very much. So I'll just give them an arrow. Like, Cody's way nicer than me. He's young. He's nice. He'll listen to you. He's not as mean as I am.
You'll still have the problem driving an hour, not using any implants.
Yeah, exactly. Do you have like stuff that lives on your shelf, like with certain stuff, so you don't have to call reps in? Do you have trouble getting reps to Maysville?
Not really. No.
Yeah, they'll come.
We definitely have like the most common stuff we use for like trauma and such. Can we pause this for a second?
Oh yeah, sure.
Come on.
Yeah, we're talking about rep stuff and you being nicer than me because you're younger than me. So
that's what we're talking about. Stuff we have on the shelf.
Stuff on the shelf. Yeah. So like we had the previous people who were here like had certain things they liked and I didn't. So I kind of was like the bad guy when we started taking stuff off the shelf. But I'm pretty old school. Like I think of myself as a young adapter of technology, but then when I think about it, I'm probably not. Yeah. Probably a little old school when it comes to implants and how like let's give it a run and see what happens, and then I'll tell you if I like it or not. Because it took me forever. Literally took me forever to start putting headless screws and metacarpal fractures. And I'm like, I just was opposed to it. Like I'm plating these things and it's awful. And the outcomes are awful. And then I started like putting compression screws in. I'm like, I was so dumb. Yeah. Like they can punch something the next day if you put the compression screw in. I'm old school from that standpoint. So like you said, we talked too much about shop, but that's one of the things. Like I wanted to have you down for a couple of reasons. One is we have some of the same people, both sides, for listening stuff. And so when we started talking about doing total hips, like however we found each other, I was like, hey, if you like to do these hips, we can try to get them up to you. And that's kind of how, we give people options here. If you're going to have a hip done, this is where you can have it done. And we had a few people who go up to Maysville. I don't know the psychology behind it.
Big city.
Well, some of it is like there's been a trend in Cynthiana for like people just go to Lexington. Mm-hmm. And it was like that for a lot of years. And so sometimes they're just like, just going to go to Lexington. And so me personally, I think the University of Kentucky is great. They have good surgeons. The process is a mess. It's really big. Yeah. It's intimidating sometimes to patients. And so sometimes it's better to go to a place like Cynthiana at the Maysville because it is smaller. It's not the same hoopla as being in the city at the university.
And I don't think people understand that, 90% of surgeries that need to be done from an orthopedic standpoint can be done by 90% of orthopedic surgeons.
Yeah, I hope that's true. You got a little more hope than I do. But I see what you're saying. Like you start to look at, it's really, we talked about this, it's your last patient. Yeah. And so if you do well by them, then for me, when things started growing into the sports medicine stuff when I was in Florida was, if a parent will trust you to operate on their kid, you can operate on them, their parents, their cousins, because that's their biggest asset.
Yeah.
Like, if they give you the green light to operate on their kid, you have that whole family at that point.
Yeah.
And so that's how sports medicine works, and they're picky as well. They should be on who does their surgery. Some of that trend became, probably one of the hardest working persons ever in our profession is James Andrews, because he never said no. He answered his phone all the time. He worked to his last day of working like a beast all day, every day. But he got his reputation by just saying yes. And some of it was good timing. He operated on Drew Brees early on. He operated on Roger Clemens before Roger Clemens was Roger Clemens.
Did you do Bo Jackson?
The Bo Jackson, yeah. The Bo Jackson thing you don't want to do. Somebody fractures or dislocates their hip and it ends up becoming AVN. You end up having to have a total hip but the way Bo Jackson was, he was rehabbing from the start. He thought he was going to play the next week.
He had a home run his first at bat.
Yeah. Well, I mean, after the hip dislocation. Dislocated his hip. He thought it was a soft tissue injury, so he's busting it, trying to get back. Turns out he had a femoral neck fracture, and he's just setting up AVN, and ends up having to have a total hip, which ends his football career. But the reason we're saying Andrew's stuff is he just worked like a maniac, but he also knew that that sports are important to people.
Yep.
It's kind of a crazy thing. Like, I'm a little weird about it, but on our walls here are college athletes and professional athletes that we worked on through the years. And I'm a little uncomfortable with that part of marketing of it, but it does matter to people.
For sure.
And so it matters to parents. It matters to other athletes that I've literally was in the waiting room and they said, "Oh, you worked on so-and-so, so we're good." Yeah. And I'm like, well, that doesn't make sense. Their collarbone's the same as yours.
Yep.
It's the same. It's the same situation. So I was really hesitant in that part of marketing initially. And when I started, we built the performance center around professional golfers. And when I was starting to get some golfers in, they were really turned off by people who do this stuff. Like, oh, they're hanging my picture and they're doing this, they're taking selfies. But if you look at sports medicine practice, that's what you do. Like, you just get the jerseys and hang the selfies.
Yep.
And it's really to celebrate the athletes who are committed enough. That's what we do for the college athletes. Like, it's hard to be a college athlete. It's hard to be a successful high school athlete. And so we want to celebrate it. When people have an injury and they recover and they go on to play, like, for us, that's a party. Like, that's our paycheck.
It's like the best part of your job.
It is. So you get it. And then some of it, lucky enough, we can turn the TV on Saturdays and see people playing college football across the country. That's a cool thing. Yeah. To be there. And, my wife makes fun of me because I call them my kids. Like, she's like, "You got a lot of kids." I was like, "Here's my kids." Like, we just had a kid, had one of my kids fly from Iowa State this weekend to get treatment, and because he's rehabbing from a surgery. And for us, that's just, for me personally, I feel proud about that because that means that someone's willing to fly from Iowa.
Yeah.
But also means that you can. One of the things I was passionate about, I'm sure you're the same, is to take what you would call city orthopedics from Dayton, Ohio, or Oklahoma City to the country.
Yep.
And you're starting to say 90%. We really want to raise the bar in our town to say you don't have to leave to get good care. And you don't have to leave Maysville to get good care. You don't have to leave Cynthiana to get good care. That helps everybody. From that standpoint, kind of raises the bar from it. So speaking to that about Maysville, like, what would you say to, what would your response be to somebody who says, how many of these have you done? So early on in your career, when you were sitting down 2 years ago, and you're a big boy now, you don't have any backup. Talk to me what you were thinking about when patients were like, "You're too young to be my surgeon," or how many of these have you done? How'd you handle that?
Oh, it was a little challenging, honestly. It's because you went from operating all the time in residency, and you may have done 500 total knees, but your name wasn't on the top of the chart, right? So, the first, several cases, I mean, I got that question often. How many total knees have you done? I don't know, 500, 600.
You mean in residency or like on? Exactly.
It's like I've done a lot.
Yeah.
I got signed off to do these. And,
Yeah, sure.
You know, we did the extra training, and I don't know. I think that's a struggle with any doctor, though. I mean,
yeah.
And I don't even know how to think about it, because in all reality, yeah, you want the most experienced guy to an extent, but I think in medicine, I think it's like this. It's like no experience, but all the knowledge and training in the world. You get to the peak of your career where you're still in the know, you're still in the newer stuff.
How old is that?
I don't know.
I'm joking. Go ahead. I'm seeing how old I am.
40, 45 probably.
Oh, crap. I passed it.
But then, and that peak is going to last for a long time. You probably got 10 years of, you're at the peak of your volume. Yeah. You're still wanting to be busy. Yeah. And then you probably get to a point where you're like, I don't need to be this busy. Family life starts happening. You want to be around your family and, vacation more. Sure. And then it probably slows down a little bit. So
you did experience that, though? Patients were like,
no,
wait a second.
All the time.
You're a little baby. How are you going to do my surgery?
You're not old enough to be a doctor.
Yeah. Yeah. The good news is that goes away, because no one's accused me anymore. Yeah. But I always had that in the back of my head. Like, not trying to make fun of it, but like, a lot of doctors have died in private jets and small planes, and I'll just hedge my bets on not doing that.
Yeah, I'm not trying to die.
My son is
how old your son?
My son's 7, and he's afraid of airplanes.
Oh, really?
Mainly because of this just like recent, like Boeing's falling apart. Yeah. Because he's watching it and he's like, I'm good. Like, I'm not flying. And so now we're like really shackled in how far we can travel if you're not going to get on an airplane. And he's convinced that you can go to vacation without me if you want, but I ain't flying.
No, he's
dead on it. He is dead on it. We had him on the podcast once. He's a little encyclopedia for baseball, and I take care of a lot of the LCA football players in Lexington. He loves that team, man. He's their previous coach, Doug Charles, who's now their like general manager, and they have a new coach this year, Oakley Watkins, who's been there for 12 years. We just did a podcast with him last week. We ended up, when I first started the Performance Center in Tampa, when I came back home, when we moved to Lexington, I had no intentions of opening it again. So I was going to let it die. And I don't know why. But I was just like, okay, I need to build something sustainable. So our thought was to bring OrthoLinks to Kentucky and bring city-level orthopedics to the rural parts of the country. So I grew up in Pikeville. Mm-hmm. And in Pikeville and Prestonsburg and Hazard, Harlan, Jackson, name the town, you kind of get what you get. And not many people move there. Yeah. And so what we wanted to do is kind of raise the bar of at least the anticipated level of care in those small towns. So I was like, I don't have time to do the Performance Center stuff. It's because we're going to try to build this footprint. And then our first experiment to bring in city orthopedics to the country is Cynthiana. And we had a lot of learning to do. When we first start, like the transition from Tampa to Cynthiana was crazy. When I first started,
very similar sized towns, right?
Yeah, exactly. I was here one week and in Florida one week, so back and forth, because I had a private practice. I couldn't just close the doors and leave. We had to kind of land that plane in some way. So I was back and forth, and Cynthiana was really the first place who would even consider that as a setup. I was like, I can't come full time. I'm here every other week. If we can work with it, we can work with it. If we're not, no is an okay answer. And so Dr. Toadvine, who was the CEO at that time, said, yeah. At first said no.
Yeah, of course.
But then, a couple of weeks later, he gets a call and he's like, let's reconsider. Let's look at it.
Was there any orthopedic surgeon here at the time?
There was an orthopedic surgeon here who was on his way out, and that was the reconsider part. Yeah. And so once he was on his way out and they were going to be without, they had, like, maybe we need to look at it as an option. It wasn't ideal and it wasn't going to be long term. I just needed a little bit of time to shut down the Florida thing and land it properly. And so they, fortunately, we landed here and they were working with that. So I was here every other week for a little bit, and that was a nightmare.
That'd be challenging.
Like going back and forth.
Was your family staying here?
Family staying here. We moved here, and then I was like, having to go back and like load stuff and do this and that. But when we started the Performance Center in Tampa, it was all around professional golfers and their thoracic rotation. Mm-hmm. So going back to your old school DO roots and talking about spinal mechanics and how it rotates. I had Ed Stiles was my guy when I was in Pikeville, so I learned a whole lot about the biomechanics of the spine and was really obsessed on how you make sports performance hacked that way. So I got this 3D motion capture machine called Dari when I was in Florida. Had Dr. Stiles come down and test his hands versus Dari, basically. So his diagnosis in hands, and then being blinded, and then measuring what differences he made in rotation on the Dari scan.
I think I remember him talking about that.
Yeah, it was insane.
When I was in medical school.
What he did, and I did him an injustice by not like having something publishable.
Yeah.
But what he did that week was insane. Like everything that he told us was measured on, like he can feel where the problem is and fix it. And he did. And we have proof of it.
That's awesome.
It's crazy. So I got really obsessed into thoracic rotation in golfers to increase their club head speed, what's called X factor, X factor stretch. And once we started getting in that flow, it really quickly turned into other athletes. With the electricity, we were using this direct current electrical stimulation that we built these protocols around. And it turned into other athletes. So when I came to Lexington, I was like, I don't know if I have time for that. So we were at an LCA game. It's where my daughter started going to high school when she's a freshman. So she's a freshman in high school. And some guy that I'd heard of, because he made his name on the camp scene, is Cutter Boley, is a junior, a quarterback at LCA. And he gets hurt in the third week of the season with the Cal game. And the prognosis that he got was like, you're going to be out a while. And I had done it now since 2017. The way we made our reputation in Tampa is when you get a bad diagnosis or prognosis, come and see us. We'll get you back faster. And that's how we built our reputation there. And so the same, when I come to Lexington, I was like, I just need to be quiet. It's not my deal. I'm not going to do anything, but I couldn't do it. So I called the head coach and I was like, have Cutter's dad call me. I can help. And like after that text, because I'd actually been at Pikeville College at the time, the same time that his son, Doug Charles' son, was there, Jordan.
Yeah.
So I kind of knew of him. He's like a youth coaching legend in Pikeville and in Lexington. So for years and years. And then he became the head coach at LCA. And so I sent him that text and he was like, who is this? Like, because he's just a star quarterback.
Yeah.
And it's a big deal. And so,
had he already signed at UK at the time?
Not yet. So the panic button's on because he made his name in this season. Now we're only 3 games into that season. He's got all these offers, but he's not committed yet. And so they were really afraid that this was going to cost him some offers. And so I said, have his dad call me. I kind of explained to his dad what I did in Tampa and, well, to speak, who we've worked on and how it'd been successful. And at that point, he's like, I'll try anything. Like, we got to get Cutter to play. And I've said this story many, many times and several times on the podcast, but I walked into the cafeteria at LCA. Cutter walks in with a walker boot and crutches. In about 20 minutes, I have him running with no walker boot and no crutches in the cafeteria while the moms are baking brownies.
That's wild.
All the parents see it. And he goes out, tells Doug, like, I don't know what just happened, but watch this. I can run. So he sprints on the field. And then after that, since that day, I get phone calls every day. I want the Cutter treatment.
I'm sure.
I want the Cutter treatment. I want the Cutter treatment because all the parents saw it. So I had no intentions of even building a performance center and didn't have a space for it. Like, I'm living in Lexington, and then it blew up. It went crazy. So after Cutter had that treatment, I ended up treating almost every football player on LCA that year. And I was doing it in my basement at my house because I didn't have an office at that point. And so we're in the basement of the house, and eventually my wife's like, okay, yeah. Well, they keep coming every night. I'm like, there's a player there. But what it did was my son got to meet all of them. And these are like his heroes. These are seniors in high school, and he's 4.5 years old. And he's looking up to all these people. Jordan. Exactly. They become his heroes. And so he knows Cutter Boley, he knows Brady Hensley, he knows Kenyatta Harge, all these people. And they all interacted with him in such a positive way that he became obsessed with LCA football. And these were his heroes. He's looking up to them. So after his kindergarten graduation, they made a video for graduation. You hold up a sign on what you want to be when you grow up. So you got firefighter, police officer, everything kids say. He put football coach.
Oh, that's different.
That's different. So the coach, Doug, sees it and calls me. He's like, "Hey, man, we're just going to make Jax's dreams come true. We're going to make him the youngest coach in the state." And they give him a huddle login and make him a coach at LCA. Awesome. And so that's how the Performance Center, like, I couldn't shut it down at that point. Yeah. It became this. I was just going to forget it. Actually, I'd met several people and was going to sell it to them. Like, hey, you can be really successful. Nobody in Lexington knows about this. Nobody knows about these treatments. Nobody in Kentucky knows about these treatments. So you can go run wild. You'll be able to solve the sports injuries world. I was just going to sell it. And then we got like to the final thing, and I was like, it's like one of my kids. I don't think I can sell it. Like, I'm going to be selfish, and I want to keep it. And then more kids would come with bad prognosis and play the next week. More kids would come, bad prognosis, play the next week. I was like, we probably shouldn't quit. Yeah, probably should keep it around. It may work for people. So that's how
definitely working for people. Yeah, it sounds like
that's how it worked in Lexington. And then now, we're sitting in a little space that used to be a sun tanning place called Chase and Rays, and so we're trying to bring that to Cynthiana now. Like, talking about bringing city orthopedics to the country. This will be the first time ever that a place like Cynthiana has had access to a performance center.
Yeah,
and
that'd be great.
So we're trying to raise the bar and say, we got college and professional athletes on the wall for 2 reasons to celebrate. Like, this is what we want for you. Like, if you have a dream to play college football, you have a dream to play college baseball, whatever it is, like, let's not let an injury throw that off.
No.
And then get you back on. So all these are really success stories for people who had an injury, worked through it, and then went on to play in college or become a professional. So we're trying to do that in Cynthiana, in a place that hadn't been done before. So there's challenges that go with that for sure. But it's brand new. Yeah, it's brand new. So we're trying to introduce it so we can do it. And that's how the Performance Center kept its feet, is all because of Cutter Boley. And I was like, you guys got to quit calling it the Cutter treatment, because I'm going to have to pay him NIL money if you keep freaking calling this treatment named after him. But that's what it was for LCA. Like, everyone knew, this is the Cutter treatment, because it was dramatic. And at one point I would have been like surprised by that, but we'd already been doing it since 2017. And so for 5 years, that's how we built our practice in Florida.
Yeah, the first person saw was like, this is witchcraft.
Yeah, exactly. Yeah, exactly. And I was like, it's not really witchcraft. And then you start getting in the nuts and bolts of what it is and how it makes a difference. It makes sense, but people see it as like this voodoo treatment. Yeah. Like, I came in a walker boot and I ran. Like, how does that work? And then traditionally, how we're trained is like, your body needs to rest. You got to do this. You got to do that. And it turns out that everything that we were taught is not true. It's just simply not true. Our body has a buffer that goes between mechanical breakdown and injury and pain. And if you can shift that pain closer to that mechanical breakdown and injury and still perform in that area with no pain, then that's how we get people back faster.
Yeah.
And, we were always taught, I was always taught that there was no modalities that would change the prognosis of how long you're going to be out. So you can go get acupuncture, you can get e-stim, you can get whatever modality you can think of with physical therapy. And it's going to help you feel better faster, but it's not going to shorten your duration of the injury, because there's a healing process that needs to happen. And we flipped that on its head really fast.
Yeah, that's awesome.
Yeah, it's just simply not true. And the way that we looked at it was, initially I would wake up like the first year and think like, what if this doesn't work tomorrow? The first professional athlete we ever had was a professional golfer who jammed his wrist on like a root and couldn't grip a golf club. Like, literally couldn't hold the golf club. And he came from the Canadian tour to me back to Florida to say, I can't hold a club. And his trainer had sent him to me. And at that point, I didn't really know what I was doing.
You didn't have any fracture?
No fracture. So we x-rayed it. We did the whole thing. Everything was good from that standpoint. I was thinking he has a hamate fracture or something that you would expect. All that stuff was okay. And then but he literally couldn't grip a golf club. And then like this, in like 20, 30 minutes, he's in the back of my clinic hitting 6 irons full on with no pain after this treatment. And I was like, what was that?
And so you don't even know what just happened.
I didn't know what happened, and I was confused by it, and it made me hit pause. And then I had to like rethink everything I knew about injury prevention and recovery. And so we spent the next couple of years just grinding, figuring out how to hack the body to recover faster.
And it's just this direct current.
It is that, yeah. And some of it is going back to the principles of how we know how the body works. And a traditional E-stem is like a sine wave. Mm-hmm. And so it's kind of hard, but an alternating current where it grabs your muscle, lets go, grabs and if you do it long enough, like you put a TENS unit on your back, it feels good while you have it on. But as soon as you take it off, there's no physiological changes.
Yeah.
With a direct current, somebody was smart enough, and it goes back way to Russian Olympic athletes. You see burns all over their skin from having to do this direct current electrical stimulation. But there was no wave that was good enough to get through the skin without burning it. And then finally they put a back wave that gets it through the skin to the tissue so it doesn't burn your skin on the way in. And it started with some old, like called Therastem and ARP wave, this old thing that like hockey players used it a lot. But we're talking really geek talk now. But the signal that it sent was so nauseous that you had to turn it up so high to get the effect that you almost couldn't stand the treatment. Like it physically hurt you to get this treatment. And so it took hockey players to do that because they're crazy.
They're crazy.
Yeah, so hockey players were fine with it, but like a 15-year-old tennis player is not okay with it because they're not used to hurting that bad.
Yeah.
And then finally, we use a machine. This is not a commercial, but we use a machine called NewFit is the company, and Newbie is the company. And we've used that along with this thing called a Phoenix Wave, and then figured out, how to use what we know. And being a DO helped me understand the spinal mechanics and what muscles I could manipulate. And if I do this is going to have the alternate effect. So having the advantage of knowing the anatomy and having knives in these places before and touching things gave me an advantage over like a physical therapy group who were just like, okay, we're going to follow these protocols. Yeah. So I started designing all this stuff to say, if I want thoracic rotation on the right side, let me think about what Ed Stiles told me about that. So if we're in type 1 spinal mechanics and side bending rotation happened in this direction or happened in that direction, I started digging into becoming obsessed with my athletes. So if you came to me, I wanted you not only to recover from injury, but then leave our place better.
Yeah.
Like, so I really got hard into like, what can we do for your specific motion that's going to make you a better athlete, that can make you go to college and or help you go to college and excel at that. So I went hard, and it was all after hours because I had a regular practice during the day. So I didn't come home for years, and I would be treating people after hours and figuring out these protocols and how to do it. And now we're pretty good at it.
That's awesome.
But it was a journey.
A lot of time and
to get there.
Effort.
And I don't even really know why I did it. And to be honest, it came because it was like, we had this professional golfer that happened right away. I was only going to do golfers because we were in Central Florida, so there's lots of golfers. But then one of my buddy's sons tweaked his hamstring, and he had a bunch of coaches coming to watch him in his spring game. He's like, "Can you do anything with your machine?" And I was like, "I don't know." I'm like, "I'll try." And we had him, again, sprinting in the parking lot in like 20 minutes with no pain with his hamstring. And he played, and he got offers. And I was like, we need to push the pause button. Like, somebody didn't teach me something. So I started digging into like, why did no one teach me this stuff? And it just so happened that a physical therapist who had a reputation of like, if you've tried therapy and it didn't work, go to him, he's going to get you right, was using the old ARP wave technology and the Therastem and all that stuff. And he literally called me one day and said, there's a box that's going to change sports medicine.
And you can do this in like 20 minutes.
Yeah, the first time takes to get a response, I can do it in 5 minutes. But to get a good response is about 45 minutes the first visit. And then after that, it's about 30 or 40 minutes for the follow-up visits. He's like, there's this box that's going to change sports medicine. You need to get one. And I didn't know what it was. I didn't know whatever. So I was like, I kind of trusted him. But also, every time he called me, I had to buy something. So
that sounds like a snake oil salesman first,
exactly.
Right?
And I was like, I don't think you understand. I'm an orthopedic surgeon. I fix people with a knife, and this is how we do stuff. He's like, I'm telling you, it's a game changer, and I've seen it work, and you need one if you're going to be a sports medicine doctor. So I was literally the first physician that bought one of these machines and really just went after it. And then the advantage I had was I saw both sides now. I've already put a knife there before. I already know what exists there. I've been to medical school. I remember what Ed Stiles taught me. So I really took that machine to the next level. The machine that was needed, that was our mechanism to do it. But I spent the time to just say, we're going to be way better than if you just get the machine off the shelf and try to use it.
That's awesome.
Yeah. So it's been a wild journey. That's where we're sitting at now, filming a podcast. But we'll see how it works in the small town. We know how it works in the city.
Yeah.
But we'll see how it works in the small town. It really just takes the star athlete to get a prognosis.
Just one.
That you fix.
You need the next Cutter
Cutter
Bowley
of Cynthiana, who comes in and says, you're going to miss 6 weeks because you have a high ankle sprain. And I say, well, how does one sound? And that's that'll fix everybody. For sure. So that's, I don't know how we started ranting about that, but I was talking about bringing the performance center and not quitting it, and then like trying to bring high level care to the small town. Just like, I mean, it's cool. I take a lot of pride in people. Like, I didn't have any direct relationship or ability to help you in ortho except for get on it, yell at you to like, hey, to do this. Like, if you have the confidence to figure out and do it. And some people listen and some people don't. Like, it's still a competitive thing. There's more people who apply than there are positions. And
By far.
My brother-in-law is going through it right now. He's a third-year medical student, and he's out doing an audition rotation right now.
Where does he go to medical school?
At LMU at Harrogate, Tennessee.
Okay,
Yeah, so
Lincoln
the
Memorial?
DO school. Lincoln Memorial, yeah.
Where's he auditioning right now?
I think he's in Toledo.
Okay. Yeah, I didn't go up there.
And so we saw him. He's starting today. We saw him on Saturday, and he's like, do you have any advice? And I was like, I'll tell you the same thing I tell every medical student. You have to be yourself, because if not, they're going to find out. So if you're a jerk, then you got to be a jerk. If you're not a jerk, then don't be a jerk. Don't try to be something you're not being.
I always told people just be normal.
Yeah.
It's amazing how rare normal was sometimes on some of these rotations.
Yeah, for sure. But then look at it from a standpoint like, be the best version of yourself, and it either has to be good enough or it's not. And it's easy for me to say that because I've been in practice for this long. It's easy for you to say that. You're on the other side of it. Talk about that, like, and it'll help some people who are listening. Talk about your progress through wanting to do general surgery and end up at Grandview. Like, what did you listen to? What did you do? What's your secret? What would you call your secret sauce to the success of navigating a med student who's going to get ortho interviews? Your personal, not advice, but like your personal, like, this is what I did.
So we had like 3 or 4 months of rotations that we get, like elective stuff in medical school.
Yeah.
And somewhere I missed that I had a month. So I had all these like lined up, and I found out I had an extra month, but I had to do it like in a week.
Yeah.
So I called around, and Grandview got me in, and I met a guy up there, Matthew Heckler, and I didn't know anything about orthopedics. I was just dumb. And he's like, here's
You
Campbell.
didn't pay attention in class when I was lecturing?
Well, you know that
You didn't come to class. You know that. You just streaming it online.
Oh, no. But in medical school, there's like 4 lectures or something in orthopedics. It's like
for sure
not that much. But he was like, here's Campbell's. I want you to read this volume in the first 3 weeks.
Great.
So I did. And it was just working hard. Don't miss the same question twice if you get asked.
Yeah.
If you don't know something, look it up.
Yeah.
Try hard.
Yeah. There's really, I ask everybody that because there's not a magic sauce. That's the point.
So.
Like, there's no formula. They say, if I do this, this, and this, like my buddy that I said, he's got a dang near perfect score on his boards. Got denied at a program that was his home program. And that doesn't make any sense, except for it's easy for me to say, like, because I'm on the other side of it and so are you. But like, I'm a firm believer that God's going to put you where he wants you and then use you where he needs to use you, whether you like it or not like it. And that sometimes it works that way, but that's not an excuse not to work hard.
No.
It's not an excuse. You can't just say, "Oh, God's got this, and I'm going to be fine." He gave you the ability to study and the ability to work and all those things, and you have to be persistent through that. But
I think you got to be happy if something doesn't work out that you gave it all you had. And
yeah, if you can put your head down and say that you did your best, and you can live with that, then you can deal with the repercussions of a non-match, or you can do something about it and go scramble somewhere. And it depends on what your disposition is.
Yep.
So it's really helpful for people to hear that, because I know several people come to me for advice, like, what do I need to do? And the best thing I could tell them is like, be the best version of yourself, and if it's good enough, it'll be good enough. And that sounds stupid.
No, I think that's great
when you're
advice,
a medical
honestly.
student, though.
Yeah.
It sounds stupid because you're like, no, I need to do something.
Because
like,
in medical school, there's a right answer.
Exactly.
Unfortunately, that's not
and
the
people
truth.
read like Student Doctor still and all this stuff that says like, this is what you have to do. Here's your formula. And then this is going to sound terrible. These are probably people who didn't match, and they're writing these Student Doctor lines or whatever it is. And so I just try to break everybody has a different path to where they need to be. And it's kind of important. You're 2 years into being grown up, but it's really important on how you enjoy life. If you get to go to work and hate it, or you get to go to work and love it. And I imagine you get to go to work and love it.
Yep.
I don't really know any orthopedic surgeons who aren't happy.
No. We all have rough days.
Yeah, there's things that you can do. And there's we got another pee break. But that's the kind of phone calls we get at the performance center stuff. Like, he's calling about a golfer who's in New Mexico right now. And so it's wild. Like, I don't know if our work meant anything, or if our words, like, I sent social media stuff. We do all this work, and I was like, I don't know if anyone hears it, but apparently they do.
It only takes a few.
It only takes a few. Yeah. Yeah, for sure. So secret sauce to get into residency is not really one. You work hard and you bust it, but like, what is, I'll say this too, just to tell people not to be it. Like, this new generation of doctors has something crazy in mind, and they believe that work-life balance is a real thing. And that comes out of their mouth all the time. You're right on the edge of it. You're just old enough to know better because you trained at Grandview. But I'm telling you, I've had medical students rotate me with it right now, and all they want to know about is like, how much time do you get off, and when can I leave today? And I'm like, that's a bad formula.
Yeah.
Like, whether we like it or don't like it, you almost have to dedicate your life to other people in this profession. And if you don't, I don't want to sound like some old stubborn dude, but like, there's just a level of attention to detail that you can only get by putting the time in and doing it.
Sure.
So as you're starting to grow your practice and you're starting to try to become the expert that people want to hire to solve their problems, if you go with the work-life balance answer early on, you're going to be in trouble.
Yeah.
And so you're talking about that climb of no experience and a whole lot of training, and you try to get to that where you're like putting it on cruise control and flying. The only way to get to that cruise control and flying is to put the work in.
Yeah.
And so it's a little concerning to me. I see medical students who are like, how much time do we get for lunch? And I was like,
from
lunch? I don't
or...
know. Like, you just get some peanut butter crackers and you get a Coke and you go about your business.
You get about 3 minutes.
Yeah. So, I mean, I'm kind of spoiled now. I'm old. So I do get some lunch occasionally, but that's like, for me, I've seen that trend in medical students rotating through, and I'm like, Lord help us. Like, we're both sitting here and we know what it is to go through residency, go through training. It's just not, there's no nice way to say it. It's not easy.
No. Like,
you make a lot of sacrifices from your life and your family to go through the training stuff, and it's not worth it.
Were you married in residency?
Yeah. And that helped it so much. Like, for me, being married in residency was a massive advantage to people who were not married.
I think for us.
Yeah.
But for our wives, it had been miserable.
Well, my wife is family practice doc, and so she was starting to practice. So
she was good.
She understood the whole thing. So she did the grind 2 years ahead of me in med student. So I saw her grinding. So I had the little cheat sheet on how to get through the first 2 years. and not lose your sanity.
Yeah.
She busted it. Her entire life from morning to night was studying, and I reaped the benefits of seeing her navigate through that. But when we went to residency, she kind of knew. She had just finished residency. And when she finished her residency 1 year in Kentucky while I was an intern in Oklahoma. And that timing was good too, because when I was an intern, we were competing for that spot, for the ortho spot.
You didn't really
So
have
I
that
never left.
distraction.
I literally never left the hospital.
Yeah.
I made friends with the IT people, and they gave me a special program that would ding when a new x-ray would come up. I would beat the orthopedic residents to the ER when there was a fracture and there's a reduction. I would have everything set up for them in the cast cart, and like, I was obsessive.
You were the original gunner.
Well, yes, because we had like 16 people showing up trying to get 2 spots.
Yeah.
And I was like, I may not get this spot. You're not going to outwork me.
Yeah.
Like, there's no chance that I'm not going to get it because you outwork me.
Yeah.
That's how my dad was. My dad was a coal miner.
Yeah.
He worked like a maniac. He dedicated his life, which he died very young, so we could have other opportunities. And so I got that from him. Like, you can't work me too hard.
Yeah.
And he was the same way. He would work any overtime shift someone would offer him, he would work it. And I'm not suggesting that's how you should be. It's just how I am. And it works for me.
Yep.
But yeah, we went through the whole thing through residency. I mean, through that internship. So my wife kind of knew. She just finished internship, but it was insanely helpful for me.
She's like, we'll see you in 4 years.
Yeah, some of it was like that. Cause I had to go to Tyler, Texas for 6 straight months. It's right when my daughter was born. It's like, my daughter's just born. I'm leaving for 6 months.
Oh, that's pretty brutal.
It was brutal. And, she's awesome. She's a rock star, and like, I've drug her all over the country. We went from Oklahoma City to Mount Sterling to Tampa, Florida, to back to Lexington.
She's well traveled.
Yeah, she grew up in Pikeville, and her whole thing in life was, I'm staying here. Like, we're helping the people here. My whole thing was not that, not that I wanted to leave, but I was just like, the road took us different places. And
see where it goes.
Yeah, we had to see where it goes, and so we still have Pikeville's still a pretty special place to us. The college and the med school, and it's we really care about it, and I'm pretty passionate. I'm there a couple times a year. I have some title there now as some director of something.
Orthopedics.
Surgery thing or something. I kind of oversee the letters of recommendation for people who are trying to do ortho and surgery stuff. So it's helpful. I get to help as many people as I can do that and talk them into like do it.
Yeah.
Yeah. Don't stand on the sideline. Don't get a tattoo that says no regards or anything. So, yeah. So talking about bringing big time stuff to small towns, what would you like to see in Maysville? Like when you're old and dead, if you spend your entire time in Maysville, who knows how that's going to work? What would you want them to say when you're dead? Like, what did you do when you brought orthopedics there to Maysville?
Man, that's a great question. Oh,
I mean, I didn't say it was going to be easy podcast. Right?
Yeah.
It's been mainly me ranting, but
I'd like to think that I brought, excellent quality care to the area, and, I treated all my patients like they would when we treated. I try to treat everybody the way I would when my mom or dad or sister treated. And, I hope we bring the technology that's available to Maysville, and I think we have. We got the most up-to-date robot for total knee replacements right here in Maysville.
Yeah.
I think we were actually the first hospital in Kentucky to have the 2.0 version of Mako.
Okay.
Which is kind of cool. Kind of helped that I was coming out of residency into Maysville.
Yeah.
And we
Did you use any of the robots in residency?
Yeah, I had a great residency. We had surgeons that were doing standard instrumentation. We did a lot of nav, my first, second, and third year.
Yeah.
And then we still had some people doing standard, but we did a lot of Rosa and Mako towards the end. Those were the only 2 robots.
Well, let's talk about Mako a little bit since we're talking about it, like just for people who don't understand what that is, because we're using this term about robot assisted random Mako thing. Like, what is it, and how do you use it in your practice for total knees?
So Mako is a robotic arm with a crazy algorithm to allow us to make our cuts on our tibia and femur perfect, essentially. Yeah. So
like pre-measured, because you do a CT scan.
Yeah, we do a CT scan of the knee, and we can see all the bony structures of the knee, and you get this preformed plan about what we're going to cut, the rotation we're going to put the implants in, how much we're going to cut here and here and here and here. And we play this little video game on it, kind of, where you take these dots so we can map the the actual anatomy to that CT image that was uploaded into the robot. Yeah. And then we fine tune our plan to like I said, to do the rotation, how much we're going to cut. Yeah. Do we want to put that knee? Like I do a kinematic knee where you would do more of a mechanical axis, but you can do any philosophy you want with that Mako. So if I got a real varus knee, I'm 3 degrees varus on the tibia, just the femur as needed. And then the robot comes in, and it has these haptic boundaries. So you cut, you're pulling the trigger, but the robot essentially just puts you in a plane where that cut is within a 0.5 millimeter of your plan, which would be the perfect cut.
Just so people know who are listening, it's not like you go sit in the corner like a Da Vinci thing and you're controlling this. Right? It's an arm. Right? Not yet. That's right. There's a new AI study about taking out gallbladders with this completely AI, independent robotic surgeon, and knowing what the cystic duct and artery look like and doing it with precision. So they're coming for our jobs, but it's a long ways away.
We get some time.
We got some time. So, but it's an arm that you actually control, right?
You're controlling it. I push and start the button. I move it in and out. Yeah. It essentially just doesn't let me get out of the plane I need to be in. Sure. And for the most part, you could cut the patellar tendon, but that's about the only structure that you could potentially damage.
Sure, because they're inside the parameters they're already made.
Yeah, and you just can't get out of it.
Sure. Yeah. And then once you make your cuts, the robot goes away, and then you're putting in cement. And do you do any non-cemented knees?
When I came out in practice, I was like 0% cemented or press fit knees. Yeah. I'm probably 75% press fit now.
Okay. Yeah. I saw the look on your face when I said cement. And you're like, what's that? What do we mix that for?
It definitely switched a lot in the last year and a half. I still cement, the older patients. Yeah. Even if I'm planning to press fit, if I don't like.
Have you ever cemented a total hip?
Just like an arthritic hip?
A primary total hip, arthritic hip.
In residency, I have.
Yeah.
I don't think
so you know how to do it.
Yeah.
It's not typically how you go to it.
Not for us. I cement all of my hemis.
Sure.
Yeah.
Because you don't like press fitting hemis.
It's controversial, but my interpretation of literature.
Oh gosh, here we go.
Is that
I'm with you.
That they should be press fit. Or I'm sorry, they should be cemented.
Yeah, I agree with you. I agree with you.
My opinion is, if I'm going to press fit, I'm probably going to do a total.
And a 91-year-old with a displaced femoral neck?
No, I'm going to cement it. Cemented hemi.
I like it. I like you sticking to your guns. Yeah. The last time I cemented a hemi was never.
Never?
Never have. No. And so we came, I was right in the craze of dual mobility, but also like neck changes for the early striker stuff. Mm-hmm. And the Accolade 1, 2, 3, I don't know what it's called. When we came in, like I just started press fitting everything. Yeah. Because of the geometry that we could get proximally, even in a osteoporotic bone, was pretty legit when it came to being able to have 3 points of fixation.
I just get worried about cracking them when I'm
I know.
Slamming it in.
It's because you just want to go fast. That's fine.
Cemented takes longer.
Well, you're right. 100% does. Yeah, so that's funny actually, and we are a product of our training.
Yeah. Well, that may not be entirely true. My training, I mean, most everybody press fit most of their hemis. Yeah. We did a few grand round type things, or journal clubs like that.
Yeah.
We convinced a few.
How fun was it to hear your attendings argue about what was right and wrong?
It was the greatest. It was awesome. The greatest.
Yeah. You would honestly, now that would be you and me.
You almost pick topics to get someone stirred up.
Yeah, for sure. Oklahoma City was a wild place. We were talking about that, but there's like north side doctors and south side doctors. And in our residency, we work with both of them.
Yeah.
So when they come together in journal club, these are competitors. They're in private practice, but they're competitors with each other. So don't get it wrong that they were trying to eat off each other's plate. And it would be wild. Some of the journal clubs are like, well, this is what I do. This is what I do. And then somebody has to one up it. And it was an amazing experience.
It's the same. There's 1,000 ways to skin a cat, right?
I don't know if there's 1,000, but I think you should skin cats. I don't know if that's controversial or not. So we talked a little bit about like you coming to Maysville and what that looks like. And then long-term goals for your practice. Like, what do you want when you reach the cruising speed? What do you want your days to look like? And I'm not talking about just from a logistics standpoint. I mean, if you're going to build something, if you're going to bring high-level stuff to Maysville and the legacy standpoint, like when you're trying to build what you see, what is that? What do you see as a practice? You want more people there? Yeah, you need more surgeons. Like, what do you think when you look at like, okay, if I'm gonna be on the cruise control thing, this is what it looks like. What do you think the next thing can happen for Maysville that's positive from an orthopedic standpoint? That's a trick question. We'll have you sit with the CEO and figure it out.
Well, I think it would be a legislature. Kentucky loses the CON requirements.
Okay. Now we're talking. Because you can go across the river in Ohio, but there's no river.
Golf hole.
And you can build a surgery center in Ohio without a certificate of need. Mm-hmm. But that's a hot topic in regards to the legislation. I think that the current administration has no intentions of getting rid of certificate of need because they are friendly with large UK expansion. That's not controversial. That's just real. Mm-hmm. That's not a political statement. That's just real. That's how it's looked. They were instrumental in the acquiring of King's Daughters into the UK network, and they were instrumental in the acquiring of Moorhead St. Clair in the UK network. And I always wanted to build a surgery center in East Kentucky.
I'm going to get fired after this.
No, it's okay. It's okay. It's easy to open. Like you work at the hospital, and I work for a hospital as well. Yeah. And it's just the conversation is I don't care who owns it. I don't care if the hospital owns it. There are indications for surgery centers.
Yep. And
they don't exist east of Lexington. So if you draw a line down the middle of Lexington and go east, there are no surgery centers in the state of Kentucky, and that's a problem.
Where we would argue the greatest need is.
Exactly. Yeah. And so people who have high deductible plans, and I may get fired too, there's just a cost difference in doing a carpal tunnel at the hospital and doing a carpal tunnel at the surgery center. I'm 100% for if the hospitals want to own the surgery center, let's do that. Make it a joint venture. Make it you own the whole thing. But you need to introduce for surgeries that don't require a hospital stay or never require a hospital stay, something for people with high deductible plans who are paying for all their care.
Yeah.
And it's a legitimate concern for people who have Blue Cross Blue Shield, but a $6,000 deductible. And, that cost difference can be significant if you go to the surgery center versus go to the hospital. And I think competition's great in everything.
Oh, yeah, for sure. It makes everybody
Competition's great. If somebody came and set a building up next to yours in Maysville and they decide to do orthopedic surgery, guess what's going to happen? Your practice is going to get better.
Yeah.
I don't know in what way, but you have to make sure it's better. Same thing here.
It's adapt or die, right?
Somebody comes to Cynthiana and starts an independent practice. I'm going to make sure our practice is better. That's just the nature of how it is. We're kind of competitive when it comes to that. But like competition solves a lot of things in healthcare. And there's a podcast with Theo Vaughn and Bernie Sanders that you should listen to about healthcare. And it's the only thing that Bernie says that makes any sense, which he gives an outline of our current situation and what it is. Now, his solution I don't agree with.
Mm-hmm. Socialized
medicine, which I do not agree with. Mm-hmm. But his outline of the current state is very accurate. And so it's worth listening to because he can outline where we are, what role insurance companies play in that, what role Physician reimbursement plays in that. I was just looking at, just to look up like the office visit number to try to make some pro formas. Our pay has been cut almost every year. And I'm not saying that we can have an argument about how much doctors should get paid. That's not the argument.
No.
The argument is everything else has become more expensive.
Yes.
And the reimbursement rates that are set by CMS or Medicare rates have continually been cut. And so there are surgeons in 1980 who were doing total hips and total knees who were making $3,000 or $4,000,
if not more,
for those total hips and total knees. Because before the HMOs came in and the PPOs come in and took over, it was a percentage of charges basically, and then you kind of made your standard charge around what it was.
Yeah, there was a time when it was fee for service.
Fee for service, and then we messed that up as physicians. We probably took advantage of it too much, pushed the bar too far, and then something had to happen. There had to be a resolution, and what happened was insane after that. But now, I'm not disclosing the rates of anything in Maysville or Cynthiana. I can tell you in Tampa, Florida, when I was in private practice, that all the insurance companies looked at me and said, we don't need you. We're going to give you a discounted rate for all of your care. So I got 60% of Medicare for my commercial insurance. That means I had to see 2 patients for every 1 patient that my competition had to see, because they said, we don't need you. We have plenty of orthopedic surgeons in Tampa, so take it or leave it. And I had to make the decision whether to take it or leave it, be a cash pay basis, not that smart, or see double the amount of people for the same amount of reimbursement, which is the route that I went. But that's insane that, right down the street in Tampa, Florida, the same service could be half the price.
Yeah, that's insane.
It turns out I was the half price place, but Florida Orthopedic Institute's right down 3 miles from me. They have 100 surgeons. And so then we had to end up getting to a place where it was like that. So certificate of need, there's no need for it. All right, what do you want to leave us with? What kind of words of advice you got for the podcast here, for all the people listening?
Words of advice: don't ride motorcycles without a helmet.
What about fireworks? You got any fireworks?
Don't even touch fireworks. That was like the worst day to be on call. In
4th of
residency.
July, yeah. 3rd of July, 4th, 5th. They just kept going. Shoot fireworks the whole time.
Oh.
Yeah. Awesome, man. Well, thanks for coming down. We'll shoot this out. We'll edit out all our ER call breaks and all the stuff that we got in. But I really just want to get you down and say hi, welcome you on the podcast, but also introduce you to people that listen to this hey, you may want to go up the road to Maysville and get your hip done.
Absolutely.
And you're obviously happy to do that. And